Welcome and thank you, everyone. If you're just joining us, this virtual UMiami Health Talk will concentrate on a very timely and important topic, COVID phobia and the dangers of delaying care. I'll be your moderator for the evening, health journalist Ileana Bravo. As I said, tonight's UMiami Health Talk is presented by UHealth Virtual Clinics, and our expert providers are ready to care for you. You can come to our facilities or we can do it virtually, wherever you are. We invite you to learn more about the measures we have in place to keep you safe, as well as your appointment scheduling options. And all you have to do is visit umiamihealth.org. Tonight, we're going to hear from three internationally known University of Miami health system experts, Dr. David Lang, Dr. Jose Romano, and Dr. Jeffrey Goldberger. Each of our expert panelists will speak on different aspects of how delaying care for emergency medical conditions is causing unnecessary deaths and long-term disabilities due to heart attacks and stroke. We're also going to cover the heightened safety measures instituted at the University of Miami Health System to keep patients safe from infection while providing them with life-saving care. I want to remind you that during each panelist presentation, we're going to poll you, the audience, on questions relevant to the discussion, and we ask you to be proactive and participate. Your answers will be anonymous, but it's an important addition to the conversation, so please take part. There's also a Q&A session that will take place at the end of the presentation. Many of you have already submitted questions in advance, but if you haven't, take a moment to look at the bottom of your Zoom screen, the toolbar that says Q&A with that thought bubble. That is where you are going to submit your questions, and we are going to review them and present them to our panelists for them to answer. So let's begin by introducing our first presenter, Dr. David Lang, who is the Clinical Chief and Medical Director of Emergency Medicine at the University of Miami Hospital and Clinics. There you see him on your screen. He is state board certified in emergency medicine and holds fellowships in the American College of Emergency Physicians and the American College of Osteopathic Emergency Physicians. He's a member of several UHealth COVID-19 planning and operational committees, which activated in January of this year to proactively prepare for and protect UHealth patients during the coronavirus epidemic. Dr. Lang's presentation will provide an overview of how the UHealth Emergency Department protects patients and staff from potential COVID infection. I hand it over to you, Dr. Lang. Take it away.
Thank you, Liana. Good evening to those who are watching. My talk tonight is actually to offer updates on how our emergency department has made changes to our processes to protect you, your family, and our staff from COVID-19 exposures. One of the things that we noticed during this whole pandemic is the number of heart attacks and number of strokes seen in hospitals have actually decreased this year. So I welcome Dr. Goldberg and Dr. Romano to join me to discuss those in depth. We have seen both locally and nationally and read articles about people worried about visiting their physician or going to the hospital in fear of getting COVID. But whether you live in South Florida or not, emergency departments remain prepared to care for you and your families. Being in an emergency department, some things won't change. You can expect to be greeted on arrival, given a brief evaluation by a triage nurse to determine two things. One, what order patients need to be seen, and two, what area of the ER is best for you. And once in an area for examination, there's an evaluation and treatment as medically indicated by our team of nurses, techs, and physicians. You may also be seen by a nurse practitioner, a physician assistant, or a residency in specialty training. After an appropriate screening exam and stabilization of condition, a decision is made to either admit, discharge, or possibly transfer you. When it's busy, in any emergency department, the triage process is to select the sickest patients to be seen first. So don't worry about it. We did not forget you if you're waiting a little bit, but it's our goal to keep the waiting times as minimal as possible. Whether you're in the waiting room, you're in an ER, or even in an inpatient hospital bed, always let a staff member know if you're feeling worse. Conditions do change, so our focus may need to change as well. To provide the correct care that we need to give you, I want you to consider bringing a few things to the emergency department. One is a picture ID. We need to know who we are treating and to make sure that we're doing the right thing for the right patient. Two is bring either a list of your medications, and that would be all your medications, or bring the bottles of medications, but include your medicines, your allergies, the names of your physicians, the names of hospitals. Let us know if you've had reactions to past medications. I suggest you bring a cell phone, an iPad, or some other device to talk to friends and family while you're in the hospital or even in the emergency department. Visitor policies in many hospitals, including ours, have changed during the pandemic. And I'll discuss that in a little further in a few minutes. And bring something warm. An ER can be cold. IV fluids can also be very cold. And one thing to realize, the University of Miami is the only university-owned multi-specialty care acute hospital in South Florida. Depending on the reason for your visit, you may be seen by a resident or a fellow physicians that are in training who are going to help us make decisions regarding your care.
Okay, thank you, Dr. Lang, which leads us to the first poll question of the evening, and we've asked our audience to kindly participate and answer these questions for us. So here's the first. Have you had a medical emergency or health condition during the pandemic but have delayed seeking care because of concern about COVID exposure? Yes or no? You see on your screen, the little box, just check the yes or the no if you have had a medical emergency or health condition during the pandemic and have delayed seeking care. It'll be interesting to see, Dr. Lang, where the audience lays here tonight as to their question. There we have it. So 55% said no.
It's a very interesting. So that's about what we're seeing, because earlier in the pandemic, emergency department volumes throughout the area and throughout the country, actually some of them decreased to about 50% of their volume. So a 55% split that would actually make sense to show that the volumes did go down. This talk is for the 45% that did delay. That this talk is to explain reasons why you shouldn't. So one of the things that we realized this year, that COVID-19 has really forced many changes upon us, for this year. In the past, patients and families walked right into the ER. They went to the waiting room, they got triaged, and when necessary, they had to wait, but everyone was in the same room, all waiting. What we do now is that patients are initially seen outside, and they receive a brief screening for possible COVID symptoms. We may ask about fever, shortness of breath, whether you had exposure to COVID, whether you had a recent COVID test, or if you have a known negative or positive COVID status. Being the University of Miami, we may also ask you if you're receiving treatment for cancer or if you're on chemotherapy or any other immunotherapy that we need to know about. If you look at the screen and you see the picture, some of the patients with mild symptoms may be asked, or if we wish to stay outside in the tent to be seen. The tent we put outside the emergency department is almost 1,500 square feet. It's actually a bit larger than some smaller area hospital emergency departments. But we can keep people out there with mild symptoms to test for COVID, to screen them for COVID, to do medical workups. Sicker patients may be brought back into the emergency department. But we do this because our purpose is clear. We don't want to expose COVID patients with our non-COVID patients. And as I said earlier, many of our patients receive treatment across the street at the Sylvester Cancer Center. And we want to maintain our practice that we had even prior to COVID of separating out our Sylvester cancer patients from patients that had possible infections. Here are some of the newer aspects we've had in our emergency department, and many other emergency departments may do the same thing. One of the things that we have is all patients are asked to wear masks, regardless of the reason they're there. Whether they have an ankle sprain, chest pain, we want them to wear a mask. We also have all the hospital staff wearing masks. Staffs that are in the areas designated for COVID have additional PPE for their protection, as well as the protection of the patients and everybody else. We removed a lot of chairs from the waiting room to maintain a personal and social distancing that complies with CDC regulations. Now, during the pandemic, we have decided to restrict visitors to both the emergency department and the hospital. And this is to maintain the safety of the patients, the staff, and the family and friends who may visit. And imagine trying to keep an appropriate distance in the hallways or elevators if we have lots of visitors, or even trying to get into the hospital after a COVID health screening can really create a traffic jam outside. So for these reasons, we actually believe it is safer for everybody, especially during periods of COVID spikes, to keep our visitor policies in place. To properly admit patients to the appropriate floor, all admitted patients are tested for COVID before they leave the ER. The COVID results are available prior to the patient leaving the department. So the hospital and the ER we have separate rooms for COVID patients, separate floors for COVID patients, separate areas for patients that we suspect have COVID. So effectively, I want everyone to think that we're running 2 different ERs and 2 different hospitals. We run 2 ERs. We run in a COVID area and a non-COVID area. The hospital is running a COVID floors and non-COVID floors. And we have done this to maintain everybody's safety. If you have mild COVID symptoms, an ER visit may not even be necessary. Mild COVID symptoms can be managed at home. However, worsening symptoms that include fevers, shortness of breath, chest pain, really should be seen by your physician or the emergency department. And I highly recommend being seen if your symptoms are worse. COVID can cause pneumonia. COVID can also cause other respiratory symptoms and other respiratory diseases that can lower your blood oxygen. These symptoms that are shown here are symptoms and signs of people that's oxygenation is actually getting a little bit lower. My recommendation is that if you have no symptoms, or if you just want a COVID test but have no symptoms, then seek out the community resources in your area. There are testing sites throughout South Florida, Dade, Broward, Palm Beach, Monroe counties, where you can get free testing. And if you avoid the emergency departments and allow us to take care of the patients that have sickness, that are getting sick and are getting worse. To conclude for emergency medicine, the University of Miami Hospital Emergency Department is prepared to take care of the same patients, the patients of Dr. Romano with strokes, the patient of Dr. Goldberger with cardiac issues that we did prior to the COVID pandemic. What we added this year is a track to take care of these patients that are getting respiratory illnesses and other sicknesses due to COVID, but don't delay your medical care. Medical care, you don't delay emergency care, obviously, but don't delay routine care. Follow up with your physicians, your nurse practitioners, your physician assistants, the people that you see for your routine health care. Don't delay that. Delaying health care, even the routine, can lead to later complications, can lead to later emergencies that you'll have to take care of. And remember to call 911. The community partner down here for emergency care and healthcare is the EMS system in 911. They have their own protocols for dealing with patients that may have COVID or do have COVID. And they've been an excellent partner with the entire community and all the hospitals in ensuring patients are brought to the right hospital safely. And finally, if you're not sure if you need emergency care or even medical care, call your healthcare provider. Many patients are seen by the physicians at University of Miami facilities. They're seen by the physician assistants or nurse practitioners. Give them a call. Don't sit at home and worry about getting sicker or what you should do. There are the hotlines of the on-call services. And to finalize, the emergency department is here when you need us. And with that, Liliana, I leave it to you.
Thank you, Dr. Lang. Important information in tonight's topic, if you're just joining us, is about the COVID phobia that people are having in seeking emergency medical care and otherwise. So we're here to put your minds at ease, and that's when we are going to transition it right now to Dr. Jose Romano, a professor of neurology at the University of Miami Miller School of Medicine, chief of the stroke division, and executive vice chair for clinical affairs in the Department of Neurology. Dr. Romano is also the medical director of the Comprehensive Stroke Center at Jackson Memorial Hospital and serves as the director of the Miller School's Vascular Neurology Training Program. Dr. Romano will speak on the importance of seeking immediate emergency care for stroke. Dr. Romano, it's all yours.
Thank you very much. It's a pleasure to be with all of you this evening. I wanted to remind you, first of all, that stroke is a group of conditions of abnormalities in the blood vessels of the brain. You can see in your top left-hand side the distribution of the types of strokes based on our Florida stroke registry. The most common type of stroke is exemplified in your left lower panel, and that's called an ischemic stroke, or stroke due to lack of blood to the brain, where a clot obstructs brain vessels, and that part of the brain is at risk for dying. The other two types of strokes are hemorrhagic strokes, both vessel that ruptures inside the brain, usually in response to high blood pressure, or an aneurysm that may rupture on the surface of the brain and cause subarachnoid hemorrhage. Those are somewhat less common, but they're all called strokes. Now, stroke overall is the fifth leading cause of death in the US, but the second or third cause of death worldwide. In the US, it causes about 170,000 deaths annually. Overall, there is about 800,000 new strokes each year. And it is estimated that over 3% of the adult US population has had a previous stroke and lives with its consequences. Moreover, there is many more silent strokes that can cause cognitive decline. In fact, stroke is the leading cause of adult long-term disability. And although the economic costs are huge to the community, to society, the cost in human suffering is really hard to fathom to patients and to their families. These are some of the consequences of untreated strokes. It is estimated that about 1 in 5 individuals with a stroke will not be able to communicate well. About half will have weakness on one side of the body. 1 in 3 will be unable to walk without assistance. 1 in 3 will have major depression, and 2 out of 3 will be unable to return to their usual activities. And therefore, it is very important to seek emergent care. So once stroke symptoms are recognized, ideally, patients should come through EMS by calling 911 to a stroke center where there is a rapid diagnosis, initially by a clinical evaluation and a CT scan, and depending on the timing and the type of stroke, perhaps advanced imaging as well. And there are two main treatments for the most common cause of stroke, ischemic stroke, where there is lack of blood to the brain. The first one is the administration by vein of a medication called a thrombolytic. It's also called TPA. And this is a clot-busting agent that will dissolve clots and restore blood flow to the brain. In addition, many of our patients that receive thrombolytics and some that are not eligible for thrombolytics may be eligible for removing of the clot with a catheter. So a catheter is threaded into the brain vessels and the clot is captured and removed. That is done by our neurointerventional colleagues, our partners in neurointerventional procedures, and we can do that up to 24 hours after the symptom onset. However, time is of the essence. What you see in these panels are images of the brain, and the normal brain is gray, and as brain dies in this type of images, it becomes white. So you see that over a few hours, the white area in the brain expands. In fact, it is estimated that for every minute of lack of blood to the brain, we lose about 1.9 million neurons. That's a lot of neurons. And we also estimate that reducing 15 minutes in time to treatment will prevent about 4 weeks of disabled life. So every minute counts in an acute stroke. Now, we recognize that the brain is a very highly specialized organ, and there are areas of the brain that are responsible for certain symptoms. So, for example, the left side of the brain is in charge of speech. The back of the brain is in charge of interpreting the signals that come from the eyes, and therefore vision is processed in the back of the brain. And you can imagine if you had an injury or a stroke to the back of the brain, you may lose vision. The same goes for the left side of the brain, losing speech. In fact, the right side of the brain controls the movement and the sensation on the contralateral side, and vice versa. So, Ileana, we have a poll question, I believe, talking about symptoms of stroke. Very good. So in this poll, we asked you which of the following is a symptom of stroke. Please go ahead and make your choice.
Yes, my apologies. The stroke symptoms include which of these following? Sudden face drooping, sudden difficulty speaking, sudden trouble seeing from one or both eyes, sudden trouble walking, dizziness, loss of balance, sudden severe headache, or all of the above. And we are seeking to educate and illuminate you tonight to see how much you know. And 100% said all of the above. So I think that they did pretty well there, Doctor.
Absolutely. Great. So you're all correct. I'm preaching to the choir here. The importance of recognizing these symptoms is that you can then call 911. So again, sudden weakness or numbness on one side of the body, including the face, sudden confusion or trouble speaking or understanding, sudden trouble seeing from either one eye or both eyes on one side of the visual field, sudden trouble walking, loss of balance or coordination, and a sudden very severe or atypical headache in somebody who's not a headachy person. And you'll see that the key word here is sudden, right? So there's this acronym that the American Stroke Association has publicized, and many of you may be aware of, and that's the acronym FAST. F for face drooping, A for arm weakness, S for speech difficulty, and T for time to call 911. There is another acronym that is also worth remembering, and that's BFAST, and that emphasizes balance, B for balance, and E for sudden change in vision for eyes. So if these symptoms occur, it is very important to seek emergent medical attention by dialing 911. Across Miami-Dade County, the paramedics, our EMS partners, have very well-established algorithms where they will take an individual's stroke symptoms to the closest stroke center. And we divide stroke centers into primary stroke centers and comprehensive stroke centers. Primary stroke centers are able to administer these thrombolytics or clot-busting agents, and the comprehensive stroke centers are able to pass these catheters into the brain vessels to remove clots and also do other neurosurgical procedures that may be appropriate. And the paramedics know which are the hospitals which capabilities. And our partners in Broward and Palm Beach also have similar algorithms. So now let me turn briefly to what has happened during the pandemic. In this graph, you see the proportion of individuals coming to hospital on a daily basis across a number of US hospitals with stroke-like symptoms. This is data actually from the utilization of advanced neuroimaging in hospitals. And as you can see here, after the first reported COVID-related deaths in the US and the declaration of a national health emergency, there was a dramatic drop of 39% in the number of patients coming to hospital with strokes. Now, we do not think that there were less strokes because of the pandemic, but actually less people coming to hospital to take care of their strokes. So what is happening to these individuals that are not seeking emergent care with an acute stroke? Well, unfortunately, some of these individuals are passing away. You'll see on the panel to your right, the location of death of Floridians in the past few months. And the most common place of death is at their home. And on your left, you see an interesting study from EMS, where you see in the gray band and the black line, the usual number of individuals that are found dead on EMS arrival after being called by family members. And you see in the dots how in April, as the pandemic was raging, there was an increased number of individuals dying at home compared to the anticipated rate. Now, some individuals are coming to hospital, they're coming late, and that is also bad. You see in the top graph a study that we did a number of years ago, where we looked at the time delay between symptom onset and dialing 911 in Florida. And you see there 300 minutes, that's 5 hours. Hopefully this is getting better with more education. But once people call 911, things move pretty rapidly. The paramedics arrive pretty rapidly. They assess patients promptly, and then they take them to the appropriate facility very rapidly. So over the next 30, 35 minutes after being called, the patient will be taken by EMS to hospital. What you'll see in the bottom graph is a study from 12 US institutions showing how the delay between stroke onset and hospital arrival grew from pre-pandemic from 442 minutes to 603 minutes. That's an extra 160 minutes. And as we mentioned, we are losing 1.9 million neurons for every minute of lack of blood to the brain. So very important to come to hospital very promptly after the onset of stroke symptoms. And we want to assure you that we have taken all the precautions to treat you appropriately. Our priorities are to, of course, keep you safe and to keep our staff safe. One of the things that we've done, in addition to dressing up and making sure that our staff do not get infected, is that we are starting to use telemedicine. So you see these telecards that we're starting to use, and we will have one individual assess a patient with a suspected stroke, and the rest of the team can be witnessing the evaluation remotely, participating in the decision-making, and also working in parallel to ensure that things move very rapidly and we can get treatment initiated as soon as possible. The other important thing that I wanted to mention to all of you is that the University of Miami is the coordinating center for the Florida Regional Center for StrokeNet. StrokeNet is a consortium of hospitals that do clinical trials funded by the National Institute of Health. We have 12 institutions across the state that participate, and we provide cutting-edge opportunities in research for conditions where there is either no good treatment or there's uncertainty about what treatment is best. So that will be available to all of you if you come to University of Miami Hospital and you're eligible to participate in one of these studies. The other important thing to remember is that the University of Miami is the Central Coordinating and Analytics Center for the Florida Stroke Collaboration, which is a consortium of over 125 hospitals across the state of Florida. This is an initiative funded by the Florida Department of Health and done in collaboration with the American Heart and American Stroke Association. where we aggregate data from all of our stroke hospitals in Florida in order to improve care and provide feedback to hospitals so they can improve. And as you can see, in the past decade, there's been some dramatic improvements. So for example, the use of thrombolytics, these clot-busting agents amongst patients that are eligible, grew from 57% in 2010 to 92% in 2019. And the door-to-needle time within 45 minutes of hospital arrival increased from 6% in 2010 to 69% in 2019. So this is a fantastic news and reassuring that our patients in Florida, across Florida, are receiving better care. Finally, I wanted to remind you that the best way to avoid a stroke is to follow a healthy lifestyle and to treat your vascular risk factors. The American Heart Association, together with the CDC, has defined Life Simple 7, these 7 health metrics, and categorized them into ideal, intermediate, and poor status. So if you control your blood pressure, your cholesterol, your glucose, you control your weight, you don't smoke, and you follow a healthy diet, then your risk of having a stroke or a heart attack are decreased dramatically. The diet is important, and again, following a healthy diet is key. Eating a lot of fruits and vegetables, oily fish, fiber-rich whole grains, and controlling your sodium intake and avoiding sugar-sweetened beverages is important. This graph shows you in each bar the health factors such as smoking, body mass index, physical activity, and so on. Green is good, red is bad, and you see that across the US, the proportion of individuals that don't follow a healthy diet is very high, 79%. The good news is that if you have all of these ideal risk factors, then your risk of having a stroke or a heart attack is significantly diminished compared to not controlling these risk factors. The ones that are important to remember are, in addition to the ones that we mentioned, is exercise. The recommendation is to engage in 150 minutes of moderate aerobic activity or 75 minutes of vigorous aerobic activity throughout the week for adults, and kids and teens should do a bit more, 60 minutes a day. And of course, to enjoy a lot of vegetables, fruits, legumes, nuts, lean animal protein and fish, and limit sweetened drinks, excess sodium, and so on. So in conclusion, I hope that I've impressed on you that stroke is preventable and treatable. So know your risk profile and get to your goal. Modify your lifestyle so you can follow a healthy diet and exercise and adhere to the medications that your physicians prescribe. Recognize stroke symptoms if they were to occur, and don't delay in calling 911. So with stroke, every minute counts. So with that, I will stop.
Thank you, Dr. Romano. Excellent tips there. And I remind the audience as we transition now to Dr. Jeffrey Goldberger that we would like for you to submit your questions using the Q&A feature at the bottom of your Zoom screen in that little toolbar area. Many of you have already done so, and they're excellent questions, so we encourage the others to do the same. With that, it's my pleasure to introduce Dr. Jeffrey Goldberger, who is chief of the UHealth Cardiovascular Division and a professor of medicine at the University of Miami Miller School of Medicine. Dr. Goldberger is an internationally known innovator in the field of heart rhythm disorders, whose research and clinical care focuses on the problems of sudden cardiac death and atrial fibrillation. Dr. Goldberger's presentation tonight will explore the risks of not seeking care during the pandemic if you have a heart issue at home, and will provide an overview of UHealth's innovative COVID-19 heart program. Dr. Goldberger, it's all yours.
Thank you, Ileana, and thank you to all the Health Talks team and to my colleagues who preceded me with wonderful presentations. So I'd like to talk to you a little bit about what's going on with COVID-19 and the heart. So first, the UHealth cardiology program has been very active in the response to COVID-19. At the very beginning, we had to work on establishing new national protocols for patient care in the setting of COVID-19. We've been working on advancing research to understand the cardiac effects of COVID-19, and I'll share some of that information with you. And we've designed actually a special clinic, our COVID-19 heart program, for people who have either suffered COVID-19 or other effects from COVID-19.
Okay, so that leads to your first poll question of the evening, Dr. Goldberger, and that is, which patients are at risk for heart complications from the COVID-19 pandemic? We seek responses from you in the audience to see what you know. Select all that apply. Hospitalized patients on ventilators, hospitalized patients on supplemental oxygen, people at home with mild to moderate symptoms, COVID-19 positive people who have no symptoms, or people who have not been diagnosed with COVID-19. Which patients, in your opinion, are at risk for heart complications from the COVID-19 pandemic from this list below? Click the ones that you think are the right answer. And we'll see how our very informed audience does tonight, Dr. Goldberg. There you go. What do you think?
Okay, so thank you for your thoughts. So when the COVID-19 pandemic started, our thoughts were the same as what most of you thought, was that the people most at risk were the people on ventilators and people on supplemental oxygen. But I think I'm going to hopefully convince you by the end of my talk that the answer is all of the above. Every single one of these patient groups is at risk of suffering heart issues related to the pandemic. So the two ways that the COVID-19 pandemic can affect the heart can be classified into essentially passive or active impacts. And the passive impact is what you heard a little bit about from Drs. Lang and Romano, is unaddressed heart problems during the pandemic. So this could be patients who decided that they weren't going to come to the emergency room to seek care for an ongoing active cardiac issue. And therefore, they're suffering effects from the pandemic, even if they're not having COVID-19. A lot of patients are not exercising and are gaining weight, and that's certainly a negative effect on the heart that's due to the pandemic. Obviously, there could be active impacts that have to do with direct infection, and we'll show you a little bit of information about that, and inflammation from the infection. So I'd really, like to highlight what Dr. Lang presented at the very beginning. There are a lot of publications and a lot of stories in the media about these kinds of issues. So this happens to be a publication from the Wall Street Journal, and you can see it's deadly to fear the emergency room. Orders to shelter in place don't apply if you're having a heart attack. So what is a heart attack? So what you see here is a picture of the arteries that are supplying the heart. This is the left main coronary artery, and it branches off into a number of different branches here. And you can see these branches continue very nicely. But you can see here, this branch abruptly cuts off. And the blood that's being supplied downstream from here, essentially, there is no downstream. So this part of the muscle is not getting supplied. And as Dr. Romano showed you for stroke, if tissue is not getting oxygen, is not getting blood supplied, the cells die. And that's what leads to a heart attack. And once again, time is tissue. So the earlier you could get to the hospital, and we can get these arteries open, the more tissue we can save and prevent progression to heart failure and other sorts of heart rhythm problems. So here's an example medical history, and this is something that unfortunately we see all the time. A 58-year-old man with diabetes, hypertension, and gastric reflux feels burning in his chest while watching TV. It's COVID, says, I'm not going to go to the hospital. He takes Tums and rests. He falls asleep. After a few hours, he awakes and he feels fine. What happened to him? Well, this is the kind of individual that might have suffered a heart attack at home and did not come to the emergency room to seek the appropriate care. So now there is actually a lot of data to show that people are not coming to the emergency rooms when they're having heart attacks. So what you see here is a plot of the weekly incidence of hospitalization for heart attacks. This is from Kaiser Permanente in Northern California. And the yellow curve here is in 2019. So this is no pandemic. And the red curve is in 2020. So you see here January and February, which is before the pandemic. You can see 2019 and 2020 essentially are overlapping. And what happens in 2020 after the pandemic hits, you see this dramatic reduction in the amount of heart attacks. These are the amount of heart attacks that are being hospitalized in the hospital. So you could ask, say, well, maybe the COVID-19 was good for heart attacks. It prevented heart attacks. But the answer is no, it really didn't prevent the heart attacks. These people, the difference between year and year are the people that are having heart attacks at home. And this is actually a very, very dramatic number. You can also see the effects of this when we look at cardiac arrests. So this is data of out-of-hospital cardiac arrests in New York. And once again, we look at a comparison period in 2019 and then 2020 in the green, which is now you can see the COVID-19 period. And you can see the dramatic rise in the number of out-of-hospital cardiac arrests that occur in the COVID-19 period. Now, certainly there are many different explanations for why the cardiac arrests are going up, one of which is COVID related. But part of it, again, is people not addressing their cardiac issues in a timely fashion and therefore suffering cardiac arrests out of hospital. So again, as I mentioned, there are publications both in the medical journals, the New England Journal, the Untold Toll, the pandemic's effects on patients without COVID-19. So again, we see heart effects not related to infection of COVID-19, but due to the pandemic itself. And you see here from the New York Times and the Wall Street Journal, again, talking about the pandemic's hidden victims, sick or dying, but not from the virus. So this is really a very real problem, and I think something that we all have to be cognizant of. All right, so now I'd like to turn our attention to the actual active part of the COVID-19 effects on the heart, and that's the infection of the heart. So this is a schematic picture of what the virus looks like. I think you've heard about the spike protein. The new vaccines basically target this spike protein. And the way the spike protein, the way the virus gets into the cell, it can't just walk into the cell. It has to have sort of a key to get into the cell. And the key to get into the cell is the spike protein. And what the key fits into is the keyhole, which is this ACE2 receptor. It's actually a receptor that sits on the cell wall. And when the virus binds to it, it can actually come into the cell wall. Now you ask, why would the cell have a keyhole for the virus? And it turns out that this ACE2 receptor is a very, very important molecule. It protects the heart from the negative effects of a molecule called angiotensin. So angiotensin can have negative effects on the heart, one of which, and on the vascular system, one of which is to raise the blood pressure. And many people take medications called ACE inhibitors or angiotensin receptor blockers. And these medications are used also to blunt the effect of angiotensin. So in essence, this ACE2 receptor is the body's own protection against the angiotensin, And the virus then is actually taking advantage of the fact that it can fit into this receptor, and that's how it gets into the cells. And you can imagine that the ACE2 is present throughout the body, but is certainly present in the heart in great numbers to protect itself from angiotensin. So the way you can get injury, and that's what we're really interested in, is injury from the heart. Injury to the heart could be direct infection from the heart, but patients who get very, very sick with COVID-19, they can have a lot of other problems. They can have low blood pressures, they can have low oxygen, they can have blood clots that form, they can get inflammation. We've heard a lot about this hyperinflammatory state. And all of these factors can also impact the heart and create myocardial injury. And in fact, when we looked at some of the early series, this is from a publication that we had in Heart Rhythm, we compiled a lot of the early series that looked at patients who were in the hospital with COVID. And they measured this protein called troponin, which is a cardiac muscle protein. And when it gets released into the blood, that's evidence of injury to the heart. And you could see that there's a fairly high percentage across all these studies, usually in about the 20% range, of leakage of this muscle protein from the heart into the bloodstream. And that's why we thought that these patients, the ones that are hospitalized, were going to have the highest risk for having long-term cardiac effects from COVID-19. So we know that viruses that affect the heart can influence the heart in the long term. So we know, for example, that patients who have had influenza have higher incidence of atrial fibrillation. We know that patients who have had myocarditis, which is that inflammation of the heart, can experience sudden cardiac death. When you look at a lot of series of patients who have died suddenly, we find myocarditis. And similarly, we can find the relationship of coronary artery disease and the inflammation from the epicardial fat. That's the tissue, that fat tissue that sits on the heart. So here you see a pathologic specimen, just to give you an idea. The pink areas here are the muscle tissue, and these dark purple dots is the inflammatory tissue that causes the myocarditis. And this is taken from a patient who had COVID-19 and shock, cardiogenic shock, so very bad heart failure. And you could see that this COVID-19 virus with its spike protein is invading into the cells of the heart. And that's what we're really concerned about. Now, as I mentioned, we were very concerned about the risks of COVID-19 affecting the heart in people who are hospitalized with this. However, in July, there was a publication out of Germany that looked at cardiac MRI of patients who had COVID, 2/3 of which were not in the hospital. And what they found was that 60%, this is now after COVID, it's not during the infection, that 60% actually had evidence of inflammation in the heart. And in fact, we are concerned about particularly our athletes who get this, because if you have inflammation in the heart and you are involved in very competitive athletics, that is what puts you at risk for sudden cardiac death. And this was a very public, here you could see the Red Sox pitcher who did have this COVID-19 heart condition, which is essentially myocarditis. So we have put together a program to screen our athletes here at the University of Miami. There aren't too many studies that have looked at this. So now we're looking at a fairly healthy group of people who have had COVID-19. There's one study out of Ohio State with 26, another study from West Virginia, 54. And as of today, we're at about 80 athletes. And among our athletes, we've only seen about 4% that have this myocarditis. But it's still a significant number because those people, if you let them continue with competitive athletics, they are at risk for sudden death. So unfortunately, those are people that we have to really restrict. So there is this post-COVID cardiac syndrome. And I think we all have to appreciate that COVID-19 can cause overt or subclinical cardiac injury or inflammation in a significant number of patients, even those that have had asymptomatic infection and those who are young and healthy. We're really concerned about this because the post-COVID cardiac syndrome may be associated with sudden cardiac death, particularly related to exertion. So the real question is, who needs to be evaluated? So our thoughts are that any individual who participates in moderate to high intensity exercise and has had COVID-19 should be screened before they return to exercise. Individuals who have residual cardiac symptoms of shortness of breath, chest pain, palpitations, or exercise intolerance should also be screened. And then finally, anyone who has been hospitalized with COVID-19, just like you all thought, people who had severe symptoms, those people should also be screened for this post-COVID cardiac syndrome. So I'd just like to conclude again with what we said at the beginning. COVID-19 and collateral damage, delays in diagnosis and care can be harmful or deadly. So certainly if you have active issues or problems, do seek appropriate care, whether it's emergency care or care with your doctor. And similarly, not taking medications. There have been a lot of questions and concerns about medications in the setting of COVID. It can also be harmful or deadly. And at the present time, there's no evidence that stopping any of these medications is beneficial, only that it could be harmful. So with that, I leave you with our COVID-19 heart program. It's designed really to address your concerns, whether there is any residual damage to your heart from a COVID-19 infection. And if you've had any serious heart issue that needs evaluation, but you did not seek attention due to the pandemic, we certainly encourage you to seek attention now. And for people who are just more in tune with their heart health due to the focus on health during these times, we would be certainly happy to work with you to keep your heart healthy. So thank you for your attention.
Thank you, Dr. Goldberger. Also terrific presentation and incredible information. So we're going to have from 5 to 10 minutes to get right into the question and answer session. And we have a lot of important ones. So let's get right to it and have our experts comment. Let's be as brief as possible so we can get as many questions in. So here's the first. Is it possible to have vague chest pains over an extended period of time and have serious heart problems if you suffer from supraventricular tachycardia? Who wants to take it?
Okay, well, I guess I will take that. Yeah, so I mean, the constellation of symptoms from supraventricular tachycardia can be very variable, and you know, certainly if you have extensive symptoms, I mean, those should definitely be evaluated. You know, without knowing any of the details, it's hard to say, you know, talk about heart damage at this time, but it's definitely something that would be worthy of evaluation.
Okay, anyone else want to comment on that? If not, I'll move on. Right, a couple questions about any connection to hypertension medications such as losartan or others like that, or ACE inhibitors, and COVID-19.
All right, go ahead.
I want to say that the CDC lists hypertension as a risk factor, you know, with COVID. Being on medication for hypertension, you remember, if you're on medication for hypertension, you still have hypertension. It's just controlled. So it is considered I don't think it makes you more susceptible. It's just a risk factor if you have it for having more complications.
Okay. And you see why this is so important, because people think, oh, now let me put off my medication, which puts them at higher risk to begin with. So important to clear that up. Now, here's a question, and I'm going to be careful for the privacy of the patient. A family member writes in about an 86-year-old, a woman with COPD who is a patient at UMHealth, and she needs another mitral valve clip. She's stable with medication, but we've been waiting to go ahead with the procedure due to being scared because of COVID. Do you recommend that we go ahead and set up the procedure?
So I work in the cardiac catheterization lab. I don't do that kind of procedure, but we have very, very detailed protocols, much like Dr. Lang described for the emergency room. It's an extremely safe environment. And for people who have procedures that need to be done, we are not recommending delaying them.
Okay. Another question very present on people's minds in hospitals: are COVID patients segregated from non-COVID patients, as well as the nursing staff and doctors who work on COVID patient floors? Let's try and get into the meat of that, because I think that's very present on patients' minds.
Maybe I can take that. Yes, we have COVID designated units. The nurses that work in those units do not work in the other units. And of course, they take all the precautions not to get infected. These patients are under the care of physicians that are dedicated to those units. In the ICUs, it will be the intensivists. And people that are not in ICUs, it may be what we call hospitalists. There may be consultants, such as me, a neurologist, that would come in to see a patient and also take care of patients in other units. But we take all the precautions by masking and wearing face shields and gloves. So we, of course, don't want to get contaminated, but we also don't want to take it to our other patients when we leave that unit.
This is one of those nebulous questions that is going to be difficult for any of you to really pinpoint, but we've heard this anecdotally. And this person says, I was admitted to UMHealth in January with pneumonia for 7 days. I was never told if this was COVID related. Now we're talking January, when really it had not, the alarms had not gone off. Do you think I had it? I coughed for a few weeks. I went in due to not being able to breathe. So there's a lot of that going on with people asking if they had it.
That's a difficult question to answer unless you really look at somebody's travel history from December and January. COVID was still more of an Asian area. It hasn't really spread to the US yet. But if you had been traveling through the region and came back, it's a possibility. I would consider it very unlikely at this point, but I wouldn't definitely say no if you had exposure to people that traveled through China, for example, or you personally were there and then came back.
Anyone else care to comment on that? I know it's very difficult to really shoot from the hip on someone that you haven't seen and don't know specifically. And here's, I think, a good question. Go ahead, Dr. Goldberg.
The only addition to that is, I mean, the one test that would help identify whether that was the case would be, looking for antibodies in the blood. Obviously, if a person has antibodies, then they have evidence of having had the infection.
Yeah. And one of our questions that had been submitted earlier also said that this person said they had COVID 6 months ago, has now tested negative 3 times, but to the description that you gave of cardiovascular lingering effects, she says great shortness of breath post-COVID, and has developed what appear to be heart issues from rapid, erratic heart rate. And, what do they do is the question. Obviously, they need to be evaluated.
Yes, that is correct. There's more and more information coming out about the post-COVID effects on the heart. In fact, 2 days ago in the Wall Street Journal, there was also another article about a syndrome called POTS, postural orthostatic tachycardia syndrome after COVID. Yes, so I encourage people who have symptoms to be evaluated.
So a quick take-home message from all of you tonight, from people asking, should I postpone my mammograms, my routine medical appointments, my regular doctor's appointments to have physicals and so forth? What can you all give as advice tonight to our audience to put them at ease?
Well, I hope that we have clarified that it is important to look after your own health, particularly during the pandemic, not delay care, ensure you don't get complications that are preventable. And of course, if you do have an emergency, come to hospital, don't delay.
I think we all were saying the same thing,
Right.
which is, continue your routine medical care, continue your exercise, continue your medications as prescribed, and seek care when you need it.
And if people feel that they need to go to the emergency room with all the precautions that you've all taken, I believe that they should feel as safe as possible to do so.
Yes, ma'am.
Okay. Well, I think that this is our time to wrap it up. We've gotten a lot of information in. I thank all of you in the audience for joining us tonight on this important and critical topic, and for our excellent presenters and presentations. Thank you so much for informing and educating. We ask all of you out there to, we're here to care for you. We can do it virtually. We can do it in our clinics. Please visit umiamihealth.org to learn more about our clinical services and in-person or virtual appointments. It's up to you. Remember, UMiami Health Talks are here, and we're going to continue to inform the public. Please complete the survey at the end of this so that we can get your feedback on other topics. Good night, all of you. Thank you so much for joining us. Have a safe night.
Thank you, everyone.
Good night.
Good evening.